Good morning, everyone. I'm Dr. Ahad Khan. This week we'll be starting various topics discussing about the pregnancy and pregnancy-related complications and diseases. Uh, Today, starting, I'll be beginning with and we'll be discussing with the physiological changes in pregnancy and its clinical implications. So, various physiological changes that can be seen in pregnancy are listed here. They are as follows: genital and body changes, cardiovascular changes, pulmonary changes, hematological changes, renal changes, nervous system changes, gastrointestinal changes, endocrine and metabolic changes. So we'll start with genital and genital changes. To start with the genital changes, the body of the uterus undergoes hyperplasia, increase in height from 7.5 centimeters to 35 centimeters, and increase in weight from 50 grams to approximately 1 kg. There is hypertrophy of uterine ligaments, and there is dextrorotation of the uterine, which is tilted and twisted to right side in 80% of the cases. Now the cervix, it becomes more edematous and it is congested and becomes soft. There is mucus plugging, cervical mucus closing of the cervical canal. There are increased secretions from these glands. Next, the vulva shows increased vascularity and varicosities. Vagina shows increased vascularity and distension of the vagina at the time of delivery. Ovary, the size of the ovary is increased, and vascularity is also increased. Pelvic ligaments, they undergo relaxation and becomes more mobile and increases in the capacity. Now let's discuss about body changes. The breast, it increases in size and vascularity, increased pigmentation of nipple and areola. Secondary areola appears, colostrum-like fluids expressed at the end of the third month. Skin changes. There is pigmentation due to increased melanocyte stimulating hormone. Linea nigra pigmentation of the linea alba, more marked below the umbilicus. Chloasma gravidarum, butterfly pigmentation of the face. Then stria gravidarum, stretch of the abdominal wall causing rupture of subcutaneous elastic fibers, forming pink lines in flanks which become white after labor. These are the pictures of each one. Next, there is a weight gain of approximately 12.5 kgs at term. The main increase occurs in the second half of the pregnancy by around half kg per week. Causes include growth of the conceptus, enlargement of the maternal organs, maternal storage of fat, increase in maternal blood and interstitial fluid. There are some skeletal changes. There is increased lumbar lordosis, relaxation of pelvic joints and ligaments due to progesterone and relaxin. Now let's move on to cardiovascular changes. So pregnancy is a high flow, low resistance state. The cardiac output increases by around 50%, mainly due to estrogen. The stroke volume increases by 30%, and the plasma volume increases by 50%. Heart rate increases by about 15 to 25%. Around 20 beats per minute is increased from the baseline. There is the systemic vascular resistance is decreased by 20%. This is due to progesterone. The systolic BP slightly decreases at around 5 to 10 mm per Hg. Diastolic BP also decreases by around 20%. That is 10 to 15 mm per Hg. Central venous pressure and femoral pressure. There is no change in CVP, and femoral venous pressure is grossly changed. It is around 2 to 3 times than the baseline. So here is the presentation of the cardiac output, stroke volume, and heart rate, and it's increased during the duration of the pregnancy. So cardiac output is the highest in the left lateral position, and it is lowest in the supine position due to compression of the vena cava by the uterus. Pressure response to angiotensin II is reduced in normal pregnancy and unchanged to noradrenaline. Next, let us discuss about pulmonary changes. The tidal volume is increased by around 30 to 40%. Minute ventilation is increased by 40%, though the respiratory rate remains somewhat the same. Residual volume decreases by 20%. Carbon dioxide decreases by 25% and allows more efficient placental transfer of CO2 from fetus. Results in a fall in plasma bicarbonate concentration. The oxygen consumption is increased by 20 to 30%. There is an increase in edema in the upper respiratory tract, and a small ET tube would be needed if intubation is indicated. The chest circumference increases by 5 to 7 centimeters, causing lower chest compliance. Elevation of the diaphragm approximately by 4 centimeters in late pregnancy due to enlarged uterus, causing dyspnea. Here are the pulmonary changes as mentioned in the previous slide. The elevated diaphragm, a widened subcostal angle, enlarged uterus compressing the vena cava. All these effects, these are all the physiological changes taking place in the pregnancy. So, pregnancy induces a state of respiratory alkalosis, which is compensated by increased renal bicarbonate excretion. Progesterone dilates the smooth muscles in the airway, but estrogen causes tissue edema and hyperplasia of the mucous glands. One should always be careful when intubating a pregnant patient. If necessary, smaller ET tubes are advisable, as mentioned earlier. Respiratory drive increases due to various factors and leads to a degree of dyspnea in the majority of patients. Avoiding a supine position is advisable. Next, we'll discuss about hematological changes in pregnancy. Plasma volume increases by around 50%, causing an edematous state. RBC volume increases by around 20 to 30%. There is a decrease in hematocrit due to relatively more plasma volume increase than the RBCs. WBC count increases slightly. T and B lymphocytes do not change, but their function is suppressed, which may make the pregnant female more susceptible to infections. Serum iron and plasma folate concentrations falls significantly. Factors increase, coagulability increases, platelet count remains unchanged. So here is the percentage change of the blood and red cells during pregnancy. The blood volume increases around 150%. RBC mass increases relatively at a lower rate by around 120%. And hematocrit falls because there is more blood volume increase than the RBC mass increase. Next, here is a summary of hematological changes in pregnancy. So, except the factor 2, factor 5, and factor 9, all other factors are increased in pregnancy. Fibrinogen, factor 7, factor 8, factor 10, von Willebrand factor, plasminogen activator 1 inhibitor, all these are increased. And about the anticoagulants, free protein S is decreased. There is no change in antithrombin 3 and protein C. So, pregnancy is a hypercoagulable state, likely owing to venous status and endothelial damage. Women with inherited hypercoagulability are predisposed to placental vascular thrombosis, raising the risk of preeclampsia, gestational hypertension, and fetal complications. There is a 5-fold increased risk of DVT in pregnancy. Increased RBC count underscores the need for iron and folate supplementation during pregnancy. Both iron and folate requirements double during pregnancy. Iron deficiency anemia is the most common cause of anemia in pregnancy. Now let us discuss about renal changes in pregnancy. The kidney size increases by a minimum of 1 centimeters. Blood flow to the kidney is increased. There is a increase in the ureteral diameter. GFR increases by around 50 to 80%. The blood urea nitrogen, creatinine, and uric acid all decreases by 25%. So, thus even a slight change in creatinine indicates a significant insult to the kidneys in pregnancy. The plasma sodium is largely unchanged. Plasma bicarbonate decreases by 20% due to bicarbonate urea. The blood pH increases slightly from 7.4 to 7.44. Urine glucose is increased frequency of urination in the third trimester due to compression of ureters by uterus. So as mentioned, the renal blood flow increases, the bipolar diameter increases, GFR increases by around 50%. There is increased proteinuria, there is glycosuria, bicarbonate urea, calciuria, and there is a decreased plasma osmolality. So now let's discuss about nervous system changes in pregnancy. Due to the fluid retention and there can be compression of nerves passing through narrow canals such as the carpal tunnel, causing pain, numbness, and weakness in the hand. Anxiety and increased mood lability, vivid nightmares, and insomnia are well documented throughout the pregnancy, although the exact causes unknown. Now let's see some gastrointestinal changes in pregnancy. There is increased salivation. Taste is altered very early in the pregnancy. There is increased appetite and thirst. There is reflux esophagitis due to relaxation of the cardiac sphincter or the lower sphincter due to progesterone and relaxin. Emesis gravidarum is morning sickness seen in 50% of the cases due to increased HCG levels. Treatment is frequent snacking and antiemetics such as doxylamine. There is decreased gastric activity which interfere with iron absorption. There is constipation due to reduced gut motility due to progesterone, increased water and salt absorption. Increased abdominal pressure leads to a risk of formation of hemorrhoids in pregnant females. In liver, there is synthesis of albumin, plasma globulin, and fibrinogen, which is increased. Globulin synthesis increases due to estrogen. Hormone-binding globulins arise. The gallbladder size increases and empties more slowly. The relaxation of gallbladder increases and the tendency of stone formation is also more. Secretion of bile is unchanged. Now, endocrinal changes in pregnancy. Anterior pituitary gland is increased in size and activity. Posterior pituitary releases oxytocin on the onset of labor. Thyroid glands increase in size and activity. Physiological goiter is present. Most pregnant women are euthyroid. Thyroid binding globulin concentrations double in pregnancy. Total T3 and T4 are increased, but not T3, but not just T3 and T4. T3 and T4. The parathyroid increases in size and activity due to and regulate calcium metabolism. Adrenals increase in size and activity. Total cortisol is increased. Free cortisol is unchanged. The placental hormones, progesterone, it is produced by the corpus luteum. Levels rise steadily during pregnancy. Outputs reach around 250 mg per day. Actions are colon activity is reduced, nausea, constipation, reduced bladder and ureteric tone, diastolic pressure is reduced, causes venous dilatation, raises temperature. Estrogen, it is produced in the ovaries in the early pregnancy. Later, estrone and estradiol produced by the placenta, which increases around 100-fold. Estradiol produced by the placenta and the fetal adrenals increase around 1,000-folds. The output levels reach up to 30 to 40 mg per day. Estradiol accounts for 85%. Actions include growth of the uterus and control its function, responsible for development of breasts along with progesterone, alter chemical and constitution of the connective tissue, becomes more pliable and causes water retention and reduces sodium excretion. Next is HCG, the first hormone to be released from developing placenta, and it is the hormone measured in pregnancy test. It acts as signal to mother's body that pregnancy has occurred by maintaining progesterone production. The human placental lactogen, next hormone, it is also known as human chorionic somatomamotropin. It is produced by placenta, acts as an insulin antagonist, and thus allowing mother to spare glucose to meet the increasing needs of the fetus. Next, prolactin. It is produced in anterior pituitary, stimulated by estrogen and sleep, inhibited by HPL and dopamine agonists, essential for lactation. Now let's come to metabolic changes in pregnancy. The carbohydrate metabolism, the pregnancy is a hyperlipidemic and glucosuric state. After mid-pregnancy, insulin resistance develops. Plasma glucose concentrations rise, maintained between around 4.5 to 5.5 millimoles per liter. Glucose crosses the placenta. The fetus uses glucose as primary energy substrate. Then transport occurs by carrier-mediated mechanism. The insulin resistance is endocrine driven via the increase in cortisol and HPA. Concentrations of glucagon and catecholamines are unaltered. Carbohydrate is deposited in the liver as glycogen. Some escapes to the general circulation. Some portion is metabolized by the tissues and converted to depot fat and stored as muscle glycogen. The first noticeable change occurs in blood sugar. It is tested by giving a load of oral glucose, known as oral glucose tolerance test. The blood sugar after meal remains high, facilitating placental transfer. With increased placental production of steroid, less glycogen is deposited in the liver and muscles. The effect of fasting is pronounced in pregnancy. Overnight fast causes hypoglycemia and produces ketone bodies. Now let's come to protein metabolism. There is a positive nitrogen balance. On average, around 500 grams of protein is retained by the end of pregnancy. Blood and urea are reduced. Fat metabolism. By the end of 30 weeks of gestation, around 4 kg of is stored in the form of depot fat in abdominal wall, back, thighs, and a modest amount in breasts. So this is a summary of the physiological changes in pregnancy. In cardiovascular system, there is diminished arterial blood pressure during second trimester, increased cardiac output, increased circulating volume, supine hypotensive syndrome. Clinical significance is relatively high blood losses may be difficult to detect. Patient should be transported in left lateral ubiquitous position. Hematological, there is relative anemia in the second and third trimester. There is leukocytosis, diminished platelets, elevated fibrinogen, normal coagulation. Clinical significance is relative anemia and a higher plasma volume may make blood losses difficult to detect. In pulmonary, there is elevated diaphragm, increased minute ventilation and tidal volume, partially compensated respiratory alkalosis. Around PCO2 is around 30 to 40. Then diminished functional residual capacity. Clinical significances, there is higher chest tube placement required to avoid entrance of the chest tube into the abdominal wall whenever needed. More difficult intubation. So smaller tubes may be needed as mentioned earlier. In the gastrointestinal changes, increased uterine volume, displacement of abdominal contents, relatively insensitive abdominal wall, delayed gastric emptying, diminished gastroesophageal sphincter tone. These are all the gastrointestinal changes. Clinical significances, viable fetus roughly correlates with fundus at the umbilicus, low sensitivity of the abdominal physical examination, more difficult intubation. Musculoskeletal changes, increased ligamentous laxity, lower center of gravity, greater back strain, higher rate of orthopedic injuries. These are the clinical significance of musculoskeletal system. That will be all, sir. Thank you.
Thank you.
Thank you, sir.
I think it was a quick recap of what the physiological changes that happen and their clinical implications. Vinay, you want to add something?
Yes, sir. So, as an intensivist, when we are treating pregnant patients, we should be aware that there is a lot of hormonal influence of the placenta, and there are a lot of mechanical adaptations which are done in a pregnant woman for a growing fetus. So, as such, the critical care is such a complex subject which deals multiple systems. When we are treating a pregnant patient, the complexity increases because we are actually treating two patients, both mother and fetus. And when we are treating a pregnant, we should always be aware of the physiological changes which happens in a pregnancy. And when we are treating them, we should be aware of the teratogenic effects of the drugs and the change in the PK/PD for the drugs. And even when you are interpreting the labs, it is different. So creatinine of 1.5 we can consider normal for a regular patient, but it is abnormal in a pregnant patient, and their immune status is reduced. When you're treating an ARDS patient, the permissive hypercapnia or permissive hypoxia, which are accepted, may not be accepted in a pregnant patient. And apart from this, there's one more thing which I would like to tell is when we are treating a patient who is in a reproductive age, a woman in a reproductive age, we should be aware that the patient might be in early pregnancy, which we may not be aware. And when we are treating with different drugs, we may probably give a teratogenic drug in an early pregnancy. So we should be aware that there is a possibility of pregnancy, especially when we are treating a reproductive age. That's it, sir.
Ghanshyam, you want to add something?
Nothing much. I think both of them have covered most things. The only thing is, see, the physiological changes of pregnancy also plays these patients at certain unique disorders, which you don't find in any other population. I'm sure that as we go through this series, we will deal with those conditions. Nothing much to add, James.
I think the important points to take home from here is while the technical issues of intubation, the upward displacement of the diaphragm, and the decreased lung volumes and the respiratory alkalosis will have a bearing on how we ventilate these patients. The target PaO2s and the target CO2s for these patients when they require targeted ventilation have to be different. While we accept conservative oxygen targets of a PaO2 of 60 in normal situations with a pH saturation of 85 and above, in this particular situation, you need to have a PaO2 of about 80 and a saturation of about 92 for achieving maternal-fetal oxygen delivery. That is the first point. Second, a normal CO2 in our conventional terms is always respiratory acidosis in pregnancy. So if a pregnant lady presents with a CO2 of 40, that means it is already a respiratory acidosis. So you need to troubleshoot why the carbon dioxide is building up and not wait till it crosses 40 or 45, 42 or 45. Alkaline phosphatase is one enzyme which traditionally gets misinterpreted, and a lot of unnecessary biliary investigations are done for these patients. So you need to understand that as well. The most important thing which came into prominence during the COVID pandemic is D-dimer. As the pregnancy reaches term, as a process of placental separation, thrombi do form in the placental bed, and that is a source for D-dimer. So a positive D-dimer probably has no relevance in a pregnant lady, and it should not be used either as a marker of venous thrombosis or as a marker of inflammation, as we used to do in the COVID pandemic. Most importantly, the coagulopathic parameters, the ROTEM and TEG patterns are a little different. They usually predict or they usually represent an enhanced clot formation and a quicker clot and a delayed clot formation. So this should be, this is one of the changes since ROTEM has become available in more hospitals and is widely being used now. The knowledge about ROTEM in pregnancy has also come into the picture. So these factors have to be taken into consideration. The last point is about volume of distribution. The volume of distribution varies greatly between the different trimesters. And just as you take into consideration the volume of distribution when you dose medicines in overloaded patients and those who got large volume fluid resuscitation, you also need to keep into account which trimester of pregnancy you are dealing with when you talk about the dosing of drugs, especially antimicrobials, in context of volume of distribution. So we need to remember that. Next week, we will look at hypertensive disorders and liver disorders. That will be done by Dr. Priyanka and moderated by Dr. Manindra. Till then, take care and wish you all a very happy new year in advance. Thank you very much. Bye.
Thank you, sir.